Good morning and welcome to the Caregiver Teleconnection. My name is Glenda Rogers. I'm going to be your facilitator for today's session with Dr. Tam Cummings. And we're so glad that you are joining us on this session today. The session is sponsored by Vitas Healthcare, and I'm going to turn this over to Candace Ramos for just a couple of minutes to tell us a little bit about Vitas. Candace.
Thank you so much, Glenda. I know you always do a great job of doing my commercial for me, but I'm here today at the beginning of the year to start us off. Thank you all so much for joining today, and thank you, Tim, for your session today. We always are so thankful to sponsor your sessions. Vitas Healthcare, we are a hospice, nation's largest hospice organization, servicing many of the states that you all listed today. With the session being about Ask Tam Cummings, asking questions. I have a couple of questions that you all should start thinking about when you are caring for someone with Alzheimer's disease or dementia. Have you noticed your loved one is increasingly unable to manage personal care or hygiene? Does your loved one seem more confused or disoriented, unable to recognize family members, less communicative or uncommunicative? Is your loved one losing weight and are experiencing difficulty swallowing and eating? Is your loved one experiencing behavioral changes such as sundowning or possibly some aggression, you know, experiencing visualizations of things that are happening that aren't really happening? Is your loved one experiencing frequent urinary tract infections or possibly developing skin wounds? Has your loved one visited the emergency department or been hospitalized in the last 6 months? If you can answer yes to any of these questions, or some of them made you go, I wonder a little bit more about that, it might be time for a conversation with Vitas. You can get more information from Vitas by visiting our website, www.vitas.com, or by calling us to schedule an information session at 1-800-93-VITAS. Thank you, and I hope you enjoyed today's session.
Thank you, Candace, and I hope you have a wonderful year. Okay, let me tell you just a little bit about Tam.
No, let's go. I really am running late, Glenda. Let's go.
Okay, we got to get going. Well, we have a question. Can I go ahead and start off with that? Because
it's probably from the person who I keep missing to schedule something for her and her family. So please don't be mad at me. We'll just keep trying till I get it. Been trying for 2 months. If it's from her, tell her I'm sorry.
Well, this is from Sheila, and she has to leave quickly too. So I wanted to go ahead and get to this question. She says, when does it become unsafe for someone with dementia, Alzheimer's, maybe stage 4, to live alone?
The criteria for movement to memory care is that the person is a danger to themselves or others. Now, when you say that, we don't mean that your loved one's got a gun and they're out robbing banks. What we mean is they don't know how to safely prepare food. In this Arctic polar blast that's coming through, they don't understand they can't go outside. They'll die in that weather. They don't understand that how to take medicine. They give money away to people that shouldn't be getting money from them. They don't understand how to pay their bills. So it's looking at behaviors that place a person at risk and at danger. The danger to others is that they're driving. That's the biggest danger to others, is that they're driving. And then as another rule, the danger is to the caregiver because of the amount of stress the caregiver is under. You may have a person whose mood is not being treated correctly. And so you've got a very angry, agitated person who's aggressive towards you. So there could be a number of different things, but the rule of thumb is they're a danger to themselves or they're a danger to others. And the danger to themselves is that they cannot take their medicine correctly, not because they don't want to, but because of brain damage. And one of the things that I've started trying out last year, Glenda, was to say to the family when this seems so confusing, and it is so very complex and confusing, if the doctor had said brain cancer, would you still ask this question? So if the doctor said, Glenda, your husband has brain cancer, would you really have handed him the keys to drive home from the doctor's office? And would you have ever given him the keys again? And so it's sort of looking at it from those two perspectives: danger to themselves, danger to others. Did that help?
Was that helpful?
Sheila?
Yes, thank you very much.
Talk amongst yourself. I have to get rid of a cavalier that wants to play fetch. So I'll be right back, Glenda. Just carry on.
She's having a heck of a morning this morning, isn't she? Her pups are after her. Let's see. I guess what I can do while she runs that way is tell you what's coming up next on the Caregiver Teleconnection. Thursday, tomorrow, 10 o'clock a.m., Lucy Barilak's going to be back with us. She's going to be talking about toileting, urinary incontinence, and dementia. And so if that's something that you're dealing with, you may want to tune in tomorrow morning. Okay, Tam, you've
Yes.
had some aha moments recently when it has to do with caregiving. Why don't you get started with some of that and we'll see what kind of questions we get.
Well, literally, as I sat down, I had an aha moment because I've been collecting questions for the last couple of weeks. And one was, well, I'll read you the question. The question is, how do I handle aggression, agitation, or outburst? So there's two parts to that question. One is, right now in this moment, how do I handle that behavior? And a lot of time that behavior is going to be handled because you're going to back away. This isn't an argument you're going to win. You can't be logical with a person with brain damage. So first of all, it's keep the caregiver safe and, make sure your person is safe as well. Then you have to go to the medical side of it. And for the medical side of it, you've got to determine where are these behaviors coming from. Now they're being driven by brain damage, right, Glenda?
Yeah, yeah.
But if we're not treating the brain damage with the tools that we do have, then the person continues to have aggression, agitation, and outburst. And so when I look at outburst, the main cause of behavior in a person with dementia is untreated pain. And the second cause is untreated depression, anxiety. And the fourth cause is the caregiver themselves and how they approached. They're speaking too quickly. They're moving too quickly. They came from the side instead of from the front. So they literally startled the person. And if your person is naturally a fighter and not a freezer or a fleer or a fawner, you're going to get a physical or verbal outburst from them. But once you learn that these behaviors do actually have meaning and we can treat these behaviors, you have to back up and look at your tools. And that's why the tools are on my website. That's why they're in my books. And you can Google them. The thing that I'm going to look at for aggression is I know people with dementia have an atypical form of depression. And the main feature of their depression is aggression, anger, and agitation because the world's not making sense to them anymore and their brain's not working right. And on some level, the person is aware of that, although not in the way that it's a cognizant thought. It's more of a fleeting, gone thought that something's wrong. So the first thing I'm always going to do is the pain assessment in advanced dementia, because one of the most common behaviors with untreated pain is physical aggression. So I will get called from a building where some lady suddenly just slapped someone. First thing you do is check their pain. And for that tool, we use the pain ad. It's all capital letters, PAINAD. And if you don't want to Google everything, you just go to the website and go down to the tool section. But the first thing I'm going to do is I'm going to measure their pain level. We don't admit to pain. This is a human social construct. We're taught early not to ever tell anyone we have pain. And throughout our lifetimes, Glenda, if you just think about your own life, nobody cared that you hurt. And part of that reason is there was no medicine for that in the 40s and the 50s and the 60s. Only in the 70s did we begin to see this sudden push of different kinds of medicines. So your parents didn't have anything to treat you with to begin with, except aspirin, camphorphenique, and castor oil. So there was no treatment. So you were told to suck it up. And if you were a male, you got an even stronger social kick that you're not supposed to have pain. And ladies, you got the very same thing. I remember having cramps so bad, I thought if somebody just pulled my legs off, at least I'd feel better. And my mother told me, get up and go to school. And there was no Tylenol, there was no Motrin, there was no magic bullet that was going to help you. And ladies, you gave birth. And a lot of you gave birth before there was an epidural. And then some of you thought, well, I'm going to give birth the way women have always given birth. And about that third constriction, you said, yeah, I want that epidural now. And probably they said it's too late. That's just how luck is with us, right? So the first thing we have to do is look at the reality that humans don't admit to pain because of how we've been taught. But the reality is pain makes us ugly. I can promise you, any one of you, when you had cramps or back pain or arthritis or whatever, you're not pleasant. No human is. And so first we do the pain ad. Then, because we know depression in people with dementia tends to have aggression as a effect of it, I'm going to do the Cornell scale for depression and dementia. And Glenda, you know, they're all observational tools because I can't ask a person to tell me what they're truly thinking because they have brain damage. It's just that simple. They have brain damage. This isn't behavior that's occurring on purpose. It's behavior that we are failing to treat for them. Does that make sense?
Mhm,
And then
absolutely.
agitation also comes from pain, depression, or anxiety. So for anxiety, I'm going to look at the Hamilton Anxiety Scale. And I'm going to go through and look at my loved one and look at each one of those behaviors. And I'm going to check for my physician whether that behavior is occurring a couple of times a week, every day, or whether it is really a constant thing that's occurring as they go along, because my doctor can't treat them otherwise, because your physician sees your loved one for 5 to 15 minutes. And you don't even realize you're supposed to say all these things to them, and they don't realize they're supposed to ask. Outburst. Glenda, most common cause of outburst is I startled you. It's actually a startle reflex. And it's the same thing as if I snuck up on a child and scared them. They would scream, they would punch, they would kick, especially if their personality is fighter. Okay. The next one, so my epiphany this morning was you not only have to look at what do I do in the immediate moment, but then you got to go back and look at how do we treat this long term. And as a side note, it's been researched and determined that once my loved one is on an antidepressant, they stay on that all the way through hospice till the end of life because of the value that it brings. Now, remember, it takes a while for antidepressants to get started, to build up in the brain to where they begin to affect the serotonin levels. Generation 4s like Effexor is one of those, Lexapro is one of those. They take effect much more rapidly. So you can talk to the doctor about which one. Anti-anxiety medicine, that's going to go into effect immediately. That's a few seconds to 30-minute rule on that one. And then your depression medicine stays till the end. Your pain medicine is every single day. Glenda, I have arthritis, and I got hit in my knees a couple of years ago. One of my dogs jumped up and hit right in my knees. And I actually went to an orthopedic and said, I think my knees are broken. And he said, oh, I'm so sorry. Your dog really started that arthritis for you. So it somehow jolted and started the arthritis. Well, last week I got bumped from the Great Dane puppy, and my right leg knee is not working at all. Well, we're in Texas where the polar air has escaped from the Arctic. That's actually what a headline said yesterday. The air had escaped. And like the air molecules got together and said, Glenda, we're going to make a break for it at noon. And my knee is worse today. My whole arthritic body is worse today. So as family caregivers, when you think my loved one's in a community, how can I help them? The way you're going to help them is you're going to make sure their pain is monitored every day, not with PRN medicine. PRN means as needed, but before it means as needed, it implies that the person the medicine is for understands that they have a medicine as needed. And your loved ones all have brain damage. How in the world would they know that? So in some of the states, it's now illegal to prescribe PRN medicine for a person with dementia. So you want to watch their pain as we go into these colder months, and especially as this storm comes through. And I know some of you are in the north where it's already hitting. You've got to increase pain medicine. People with dementia and arthritis, and most older people have arthritis. That's one of the bad things about aging. But what happens is you begin to feel the storm 48 to 72 hours before it actually comes to your area, because barometric pressure is having subtle changes that affect the fluid in the joints. And that's why the weatherman's not good at what he does. But if you really want to know the weather, ask the dementia folks, and they'll tell you something bad's fixing to happen because of their behavior. They're already hurting. So as a rule of thumb, 2 days before the storm arrives with your loved one, you want to increase their Tylenol, ibuprofen, Aleve, pain medicine, whatever it is. Speak with your doctor and begin to administer a higher dosage of medication as the storm comes so that they're not so behavioral once the storm is here. Does that make sense?
Yes, I'm
Okay.
going to do the same thing, Tam.
You know, I got up this morning, my doctor said, don't take that Celebrex every day because, you know, we don't want your kidneys to shut down. And I said, well, I think I have my father, the alcoholic's kidneys, so I feel good about that. But this morning I got up and said, yeah, I'm going to have the extra one because the storm
Wow.
is going to be here in 12 hours. We'll
Right.
have the storm hitting here. And then one of the questions was, how do I redirect repetitive behaviors or questions? You can't. You just respond to them pleasantly. The repetition is not a cognitive moment that you can redirect. It is the brain hung on a loop, and all you can do is be pleasant. And so think about the story where for 45 minutes, I drove a retired 96-year-old Air Force colonel back from his neurologist to his house. And for 45 minutes, we had the same conversation, which was, so are you married? Were you ever at the Pentagon? Do you have any children? Isn't it a lovely day? And then 15 seconds after I finished speaking, the whole conversation would repeat. It's not purposeful behavior, but keep a smile in your face, keep a smile in your voice, because they can pick up on your emotion. And if you're agitated, they get agitated. So you just have to pleasantly keep going. Food, however, is a wonderful redirector. So if it's absolutely driving you crazy, make them something to eat. And Glenda, you don't have to make a baked Alaska. You can make a piece of toast with butter and jelly, with honey. You can get crackers with jelly and honey, bananas. Popcorn is a great redirector, because when have you ever smelled popcorn and not wanted it? But you've got to be aware of your loved one's choking risk. So just look for food as a redirector, and they're not going to develop diabetes. They're dying from a brain disease. So sweet things can be very helpful. If your person is diabetic, use sweet treats that are diabetic approved. Just remember that to a person with dementia, that bag of diabetic candy gets interpreted as I can eat the whole bag. And of course, that's not how it was intended. And then don't forget about graham crackers. We now have chocolate graham crackers, cinnamon graham crackers. They come as teddy bears, little rabbits. You can use graham crackers too. So look around. Every extra calorie you give them is all going to come off, but you'll know that they were happy.
Great. We've gotten some interesting things that I've not heard on in our chat box today. So if it's okay with you, I'll go with that right now.
Fire away.
Fire away. Okay, Anna, the reason I'm reading yours, Anna, that you sent to me is because I want to give you kudos for this. Anna says, my most recent blood work was not good and gave me a wake-up call. I talked it over with my doctor, and if I have not improved my own health situation by the next appointment in April, that will be my time to get serious about not being the full-time at-home caregiver and begin transition to a memory care facility, because I am not going to be a statistic. Kudos to you, Anna. Take care of yourself. Yeah, for sure.
Oh, can you read the part about the what was the medical thing? Did you say?
She just said that her blood work wasn't good, and if she hasn't improved her own health situation by her April appointment, then she's going to get serious about moving towards memory care for her loved one.
So I got a call from a person like that.
Oh, you did?
And we had a meeting, and then one of the family members called and said, yeah, mom's in the hospital with a cardiac arrest or some cardiac event. Well, then they came back and said, well, you know, she may be okay. So she came back home, and he has an unusual dementia, and it's very difficult and very challenging. And of course, she's worried about money. Who isn't, right? Especially with this disease. And we talked about a plan. We're going to get him moved. She didn't move him. It just wasn't time. Maybe she'd move him in 3 more months. 3 more months, she'll move him. She ended up back in the ER with one of the valves in her heart is having the effects of anxiety and stress, and it's not working correctly. So she ends up back in the hospital. The cardiologist said to her, oh, I think you can do care at home for 6 more months.
No.
the friend, the nurse who knows everything about dementia because her father had Alzheimer's. This is not Alzheimer's, and this person is not this lady's father. This is her husband. So totally different dynamic there about care. The nurse who's not a dementia specialist said, oh yeah, I think you can do 6 more months. What the person with the heart condition is not factoring in is neither one of these professionals are dementia specialists. And that cardiologist has no idea the level of care that is required by an at-home caregiver taking care of a spouse and taking care of a spouse with difficult behaviors. And so her challenge is to move past compassion fatigue, secondary traumatic stress disorder, which we know caregivers develop, and probably at this point, post-traumatic stress disorder. So most of you on here very likely would test for post-traumatic stress disorder because of the stress of what you've doing and because of how long you've been doing it. But in talking to her, it's trying to help her understand that the cardiologist is not a dementia expert. And if the doctor said to you, you've got this many more months, that to me as a dementia expert says you need to make a move now because you will become the statistic. And my concern about this lady is that she has gone so far. Is she about to become a statistic anyway? Because we certainly do see that. So I would encourage you, if any physician said to you, you've got 6 more months of care you can do before you get really, really sick. Well, they don't have a crystal ball and they have no idea that what they've actually said to you is you're doing the work of 12 people. You can do that for 6 more months. And that's ridiculous. It's just ridiculous. So I encourage you to take care of yourself. And Glenda, you and I both fully believe no one with dementia would be happy if they knew what you were doing as a caregiver, that you were literally risking your own life when they have a terminal disease and that there is care for them. And for some of you, that's not an option. And we have to talk about different ways that we can get you spelled through this disease so that you do survive it. But I very much encourage you to follow your heart, which is it's time. It's absolutely time. If you're on this phone call, it's time, because otherwise you wouldn't be looking for outside information. And I think when you look at the Bristol scale for activities of daily living, which was developed for dementia, I think what I've seen, Glenda, and you and I have talked about this, especially over the last year, is that so many of you have not been caregivers for 2 years or 5 years. You've been caregivers for a decade or more. Some of you are in a second marriage and are probably realizing I married a person whose dementia was already there. You just didn't know what to look for. And so how do you deal with that? And the way you deal with it is you keep yourself alive because your spouse would be happy to know what you're doing.
Right. Anna followed up and she said her triglycerides continue to increase and her A1C went over 6 for the first time. So she's, she's definitely needing to take care of this.
And Glenda, I think one of the things we forget about is respite care, because the reality is they keep building these $1 million communities with these incredible fees of what is required to pay a staff to do care, but they don't seem to factor in that most of us couldn't afford those places. And so when you have to balance what is going to be left for me to live on the rest of my life and what is needed for care, for some folks, it's literally the way you're going to make it is you're going to put them in care for a month and take a month to get your feet back under you. And that doesn't mean take a month for you to go sit in the nursing home or the memory care for 8 hours a day, because now you're paying people and you're doing their job, because the staff will leave you alone because you're with your spouse or your loved one, and they'll let you do all of the care. Yeah. So look at respite care. And when you look at respite care, plan it for a month because you need a month. Do not go every day. Don't go back the first week, because that first week you need to just sleep. Then clean your house, go see grandkids, call an old girlfriend or a boyfriend from high school. I meant guy friend. I didn't mean call your old boyfriend from high school. Glenn, you're still married to a guy that's in the nursing home. That's not what we're talking about. But call an old friend from school. Somebody you hadn't talked to. Your old friends are still your old friends, and you will pick up right where you left off. And some of the folks that have reached back out to me have said that saved their life. So not everybody can do 12 months, but a lot of people can do a month and don't realize it.
Yeah.
Okay. And check with your area agency on aging about respite care, because some of the regions are able to actually pay for that month of care. So that money's out there. It's our tax dollars. Let's use it.
And
Okay.
it's the beginning of their fiscal year, so that money may be more likely to be there now than if you wait till summer. So you gotta keep that in mind too.
That's a good thing to know.
That's right. Shanda has a burning question. She says, my lovely mom is in advanced dementia. She's experiencing vocalization. She screams out and makes noise that never turns off and can go on for over 24
Pain.
hours.
Yeah, that's pain.
Yeah. Seroquel, 50 milligrams, just started. Just wondering, will it eventually turn the vocalizations off completely?
No, they're
She may be
treating it
aware
wrong.
she's even doing it, which I'm sure she probably is not aware.
Yeah, it's the wrong medication. This is not psychotic behavior. This is pain behavior. So
Hmm.
take your pain ad and look at your mom and fill it out. And it's just that the bulk of times that we see this, it is untreated pain. So imagine if all that socialization about not feeling pain, not expressing pain, what if that was suddenly taken away from you because of brain damage? You would react to the pain that you're in.
Yeah.
And how old is mom?
She doesn't say, but listening to your discussion this morning, she says she realizes now she seems in pain, but she can't say it. So
Sorry,
she-
she's
well,
72. I'm sorry, she's 72.
72. Okay, so I'm 63 and I hurt horribly today. So you got to go with arthritis, tendonitis, bursitis. How many pregnancies did she have? Any history of broken bones, any history of falls, any history of sprains, any history of physical injury. And then cold weather hurts. But I would do the pain ad on her immediately and then get with the doctor. Your biggest pushback is going to come from your doctor. Folks can have now, I'm not saying this so you do it. You check with your doctor before you do anything, but humans can have 3,000 milligrams a day of ibuprofen, Tylenol, or Aleve. And the most I ever see somebody on is 150. 150 milligrams of Tylenol, ibuprofen, or Aleve does not even begin to touch the arthritis I have just in my fingers. So how would it do my whole body? Yeah. So I take a prescription level arthritic drug called Celebrex. And for the next few weeks, I get to take 2 a day. So I'm very happy. But you've got to talk to the doctor. You've got to make sure that this isn't the doctor's mother. I don't know if y'all have noticed this, but it's not their husband. It's not their wife. It's not their mom. Yeah. It's not their dad. So the level of what you're feeling and what you're seeing is not the same. So you fill out your pain ad because it's a piece of medical paperwork. And that then gives you the strength to be, because it's hard to stand up to a doctor unless you have RN after your name, then you're not scared. But it's hard to stand up to a doctor and to be able to say to them, you're not treating my person correctly. And then what they're going to try to do is give a PRN. And again, why would you give a PRN to somebody with brain damage? And then you can't expect the nurse in the community to understand your person's in pain because they haven't been trained for that. And then you need to understand the way the community works. A med aid is pushing medication who is an untrained person who's simply had a class in how to give medication out. And so they're not aware to be watching your person. So it all comes back to you and the doctor. Your loved one can have, I knew a 96-year-old lady once, Glenda, she was on 10, what's that codeine 3 one? The one they all want, hydrocodone. She was on 10 hydrocodone a day and had been on it for 10 years. And I wasn't about to touch her medicine. It worked. She wasn't in pain. She got up and did stuff. So the behavior you're describing is pain behavior, not antipsychotic behavior.
Okay. Shanda, you were right. I'm glad you tuned in today. It was just for you. Tisha wanted to let you know that you're welcome. She has still not been able to get her mom to stop driving. She put the car in the shop, told the people not to fix it. The mom found the car, threatened to call the police on the mechanic. She's very strong-willed. She doesn't know what to do at this point in time. She wants to call the police and make them aware. But then she's concerned about the insurance not paying if something happens. Do you have any suggestions?
Wow. Are you in a city or rural area?
We're in the city of Mobile. Hi, Dr. Tam. This is Tisha Dixon.
Oh, this is the lady. Okay,
yeah,
I'm
this
so
is the lady.
we're going to
I
get
said
together. We
Tisha,
are going to
wanted
get
you
together.
to know.
Yeah. Tisha, I started with, if you're out there, I'm bad. It is really, especially in our country, it's just one of the hardest things to do. And it could be that if y'all have a relationship with a local policeman, that he or she can come up and tell your mother, I'm sorry, you can't drive anymore. And we can blame them, we can blame the doctor. It is one of the hardest things to do. And you did such a wonderful thing of getting the car away, getting it out of vision. And of course, she tracked it right down to where it went. So that's that cognitive reserve in effect. I think this is probably going to require maybe anxiety medicine, because the driving could be sundown related, that she just feels the need to move and go somewhere else because of how she's always lived her life. So let's impair the car again, or let's just get the car gone completely. And maybe we can have the police tell her it was stolen or something and just keep delaying her. We're going to talk about this, Tisha, when we meet.
Okay. Thank
Oh
you.
my goodness.
You'll just send me a
Good
Zoom
luck.
meeting for Sunday, Tisha. That'd be great.
Okay. Okay. Sounds good.
All right.
Thank you.
I'm glad y'all
I
are
can't
meeting.
tell you how much sleep I've lost over Tisha. I wake up in the night and go, and I still haven't talked to that lady and her family. My God, I've lost the number.
Well, that
You
was who
did.
it
You
was.
did try, Dr. Tam. We wasn't available at one time. In all fairness, so
You are the kindest person. I got to tell you. Yes, ma'am.
Thank you, Tisha. I know that, taking away somebody's car keys or the car, it means so much. And as I age, I'm understanding how much it means.
Independence. Yeah,
Yeah,
absolutely.
yeah.
And it's unusual because it's harder to take men's keys away in that age group, because that car was how you went out with girls.
ah,
So it has an extra level of independence to it. Yeah.
and
Why
Gordon
don't
is
they
saying,
go buy
yeah,
a Corvette in a midlife crisis, right? All
Yeah.
cars. Yeah.
exactly. Okay, Gordon, forgive me. I'm going to kind of zoom through what you've put up here because it's very detailed. Gordon's wife, well, she's been diagnosed with some form of dementia for sure. She has cognitive reserve because she was a mathematician and a teacher. She's wondering if he's wondering if she has inherited some of this from her family. She had a brother that recently died of Parkinson's. An FTD tool puts her at 5 or 6, has flashes of mental clarity and good memory. He said he's reading emerging literature that is linking FTD and Parkinson's. Are you seeing a linkage, especially apparently apparent familial, that's not easy to say, connections? What do you
There's
think on that?
there is actually a connection between the movement disorders of frontal temporal dementia and Parkinson's. I would go to nih.gov to look for research on that. And then the medical school in Central Florida, which may be Central Florida Medical School. I met one of the research geriatricians there who is very much a specialist in that particular thing. So that is relatively new information that's been determined. As a rule of thumb, this is Mr. Gordon, right? How old
Gordon.
is
That's my first name.
There he is.
Yes, sir.
Gordon.
How old is your wife?
She is 70.
Okay, so she never played football. We can take that one off. It's not Huntington's. We can take that one off. Was
No.
she a drinker?
No, never.
Okay, we can take that one off. Going to put a little star next to Parkinson's. Okay, then a little star next to the FTDs. Then we're also going to put just a dot next to Lewy bodies, because Lewy bodies Parkinson's is a variant of Lewy bodies. And then any kind of cardiovascular.
No.
So we'll ignore vascular, and then we'll put a little star next to Alzheimer's as well. Okay, so Alzheimer's is a first cousin of FTD. Alzheimer's is a first cousin of Parkinson's. There is research that indicates very rare forms of some of the movement disorders of FTD do also have a Parkinson's dementia as well. And then with FTD, you would assume at this point that Alzheimer's will have begun as well. So I would stage her on the FTD staging tool as
That's what I
to
have.
how advanced the disease is. And you're absolutely correct. There is a Parkinson's that goes with that. It's just rare.
Yeah. She has several stage 6 characteristics. She's had her instrumental activities have been pretty much gone. Her executive function has been gone for a decade.
Hmm.
And she has a comorbidity. She has what's called, it's a very rare 1 in 2 million condition called schwannomatosis, where she grows benign nerve sheath tumors throughout her body. So she's in severe pain all the time.
Mhm.
And she's under care of MD Anderson's pain management and for her schwannomatosis. So, I mean, she's taking methadone, Dilaudid, and several other pain meds just to survive. Her
She
pain
would need-
scale is 1 to 50, not 1 to 10.
Yeah.
Oh, my.
Yeah.
Hmm.
You think about your nerves inflamed.
Hmm.
Think about your whole body's nerves inflamed, and you would just, I just can't imagine the misery. Does the medicine seem to be helping with the pain?
It's a roller coaster. It helps, but then it starts knocking her out. Sometimes I have a hard time deciding, is this the dementia talking or is it the pain meds talking? You know, when she goes through these low spells where I'm thinking, oh, is this a decline? You know, where she'll just basically zone out. She's got a lot of things like typical rummaging activities, obsessive clipping of the carpet and loose threads, and you know, a lot of typical dementia activities.
It's very
It's so
normal.
strange. It's so strange though that there are times where she has mental clarity. I speak with her like you and I are talking.
Mhm.
And
And that's
yet,
the part that makes you think you're crazy.
yes, in fact, she thinks I am and thinks I'm the one that needs to be tested.
Oh.
So every caregiver on here whose family loved one has accused you of being crazy, would you please raise your hand? So I think that's a normal thing that y'all get the brunt of it, because the human brain can't realize it's damaged. And I don't remember that I just put salt in my coffee, and you're telling me that, and I didn't do that. So you must be crazy. And you're
I don't
trying to
take too
drive
much.
me.
I don't want to take too much time. I'm her sole caregiver. I have no family nearby. I still
Okay.
work full time, and that's part of my sanity as far as respite, to get to come to work with a supportive work environment. And then I run, I listen to a sermon podcast. I'm in a dementia support group. I feel like I've got a fairly
Which
balanced.
FTD was she? Yeah.
Pardon?
Which FTD was she diagnosed with?
It was a partial, like 2 hour, and he basically just said a severe major, you know, the psychologists use the term major neurocognitive disorder instead of just saying dementia.
That's the new name for dementia. Yeah,
it's
that's the new name.
psychobabble that no one can remember. So just call it dementia.
They thought it would be easier for people to understand, but they never sent out a release that said we're changing the word dementia to major neurocognitive disease. And then
there's not even a good acronym for that.
So Mr. Evans, they didn't tell you which FTD she has?
No, they didn't even say FTD. They just, and I can't get her back down. I've got her appointments to go do like the 4 hour testing, the full battery.
Sir, if you're checking stage 6, there's no reason to put her through that.
That's what I've decided. Plus, because she doesn't she has a nosognosia. She doesn't recognize there's anything wrong with her. So there's no way I'm going to get her to those places.
Do you have an itty bitty dementia book so you can look at the FTDs?
No, but I read voraciously.
Go to theaftd.org. That's the Association of Frontal Temporal Dementia.org. In the menu, click on what is FTD. That will bring up the clinical features of the 9 FTDs. For the most part, Mr. Evans, when I meet a family, all they've been told is FTD, or it's sort of been alluded to. But once you read the clinical features, the family member very quickly says it's this one right here, because they are very, very distinctive. So It
I'm
helps to
diagnosing her as BV FTD.
behavioral
Behavior-
variant.
Yeah.
That's very, very challenging. I'm very sorry. So I would read up on that. You can YouTube the University of California, San Francisco Medical School, and you'll get everything from a 30-second tutorial on swallowing to 3-hour mini medical conferences that you'd be able to understand what they're talking about. But that is one of the big research areas. His name is Dr. Barry. I can't remember his last name. You can actually talk to him, but what you're dealing with is extremely difficult. Does she fixate on a food?
She did for a while with French toast, sweets,
Yeah.
But now she's forgotten what French toast is almost, she'll get on a binge on something and then it'll just suddenly go away.
Yeah. That's one of the classic features of behavioral variant. So if she's, you feel like she's stage 5 with stage 6 features, that actually means she's in stage 6. There would be no reason to take her for any more testing. I mean, why would we want to do that to her? And then anticipate that you should begin to see very significant declines in her. FTD
I'm
folks.
seeing that now.
Okay.
She's
FTD,
sleeping much more.
Yeah.
She's been incontinent for quite a long time,
Yeah.
urinary, and now she's getting a fair amount of fecal incontinence as well.
So that's normal. Bladder incontinence occurs first, and then bowel incontinence is a stage 6 feature if it's not vascular dementia. So that follows the progression of the disease. And then I wouldn't send her for any more testing. I would look at the stuff on behavioral variant because it does help to give the monster a name. The Parkinson's is going to make her that much more unsteady and out of balance, which she already is. And rarely are they bedbound in the final stage of life for longer than 2 weeks. They are sort of mobile until suddenly they're not. I would reach out to my doctor for a hospice order and go ahead and get that care started. Because it's another layer of professional care that comes in that looks at her, that during the day there's someone coming by to check on her. It gives you someone to talk to, social worker, pastor, and I would go ahead and get that started, sir.
Okay, thank you.
Okay.
It's very strange to be this far advanced and yet have enough cognitive reserve still there that she can sound perfectly lucid at times.
Yeah. And that just becomes shorter and shorter. Yeah. And it's because I think one of the hardest things for families that don't have the Alzheimer's dementias is that you're dealing with dementia that's not written about a lot. And so you don't see these behaviors as being normal as part of the disease process, and other people miss it. So a lot of times, one of the things Glenda and I talk about is families of people with FTD or vascular dementia or Lewy bodies or Parkinson's. They don't get the same support because the people around them don't recognize this person's brain is still dying. It just doesn't die in the order that the Alzheimer's brain dies in, because the disease starts in a different area of the brain and it moves to different areas of the brain.
Yeah.
Okay. So also look at the things that the frontal lobe is responsible for and the behaviors that the temporal lobes are responsible for. And that helps take some of the pain and hurt away, because you realize it's not intentional and it's not purposeful. They're simply responding to pieces of the brain that don't exist anymore and to what those pieces should have done normally. And then when you add in, the minute Glenda said mathematician and teacher, I was just like, oh my God, it is. There are people we are afraid of with dementia, and one of them is a teacher, one of them is a person who does math, one of them is a nurse, because they continue to do those things that they've always done. And to be that person, they were pretty smart to begin with. So we're usually dealing with cognitive reserve. People who are mathematic are very logic driven, so they can stay focused on something, and very difficult to redirect. So just hang in there, keep doing all the things you're doing. Make sure you take your Zaret's burden interview test, Glenda, the Zaret's test, which measures the stress level of the caregiver. And you can either Google that or you can go to my website to the tool section.
Yeah. By the way, I use your website a lot, and I have done that. I'm pretty much covering every one of your tools. And my stress level is fairly low because I've managed to keep my life pretty balanced. But it's getting more difficult to, the hardest part of this whole thing is that because of her lack of impulse control, is her flashes of irrational, horrid anger, where she accuses me and calls me every name in the book. She doesn't cuss. You talked one time about all the cuss words. She was so sheltered. She doesn't know all the cuss words, but she does know how to hurt somebody with her words. And I just have to let it wash off of me and know that this is a disease. But when you're in the moment, it's really difficult to do that and trying to keep from getting anger back, which does no good. You can't argue with a dementia patient.
Just got to go brain cancer, brain cancer, brain cancer. It changes how you interpret that information from them. Because because we have such a poor understanding of dementia, it's so easy to think they understand what they're saying. They're doing this on purpose. They mean to hurt me. And when you translate it all back to brain cancer, you realize they're not in control. They're not doing it to hurt you. They're responding to stimulus.
Yeah. By the way, she's wheelchair bound, but she thinks she should be able to drive. But she hasn't driven a car in 5 years, and she's not going to. But she thinks she should be able to.
Oh yeah, and it's again, anosognosia, the brain not realizing it's damaged.
Yeah.
Thank you so much, Gordon, and bless you for what you do for her. My goodness.
Well, thank you for spending a few moments with me. I appreciate it.
Oh,
thank you.
absolutely.
Okay, Kelly, she says, doesn't respite care just delay the inevitable? I think it's about you, Kelly.
I know. I was having a conversation with Anna, and what I'm realizing it's about me. For some reason, I'm really struggling about letting go. And I think some of it is because his blood pressure is so unpredictable, but at some point I have respite during the day, but sometimes that's more stressful. I haven't taken a trip in a while, and so I think it's about me and I need to figure out some
It's
things.
about you, Kelly. It is definitely about you and taking care of yourself. Yeah, for sure. And I want to say thank you to Anna. I'm looking at your conversation right now. And so Anna's kind of leading the way for you.
Yeah, she is.
That's good.
And you really do have to find a way to look at yourself and understand this is a horribly terrible decision. And it can, because of how overwhelmed and exhausted you are, that it is just so easy for you to think that somehow you're supposed to do more, or that when it gets really bad and you're not able to see it is really bad. I can tell you, when I meet a family caregiver, you look worse than the person who's terminally ill. And it's from the stress of all the care that you do. And Kelly, you look tired.
I am.
Yeah.
So, and the reason we recommend respite care for a month, if you can afford it, is to get your feet back underneath you so that you can go on a vacation. And you'd be amazed how many blood pressure cuffs are in a nursing home or a memory. They're literally dripping off the walls. And here's a crazy thing. Every single person in that building has been trained on how to take blood pressure.
Yeah.
So the caregiver for your spouse knows how to take blood pressure.
Yeah.
So
thank you.
there, and if that blood pressure drops and they need 911, they actually practice protocol on getting someone out with the ambulance service as quickly as possible. So by the time the ambulance gets there, his chart's already been copied, his DRN's already been copied, his medications have been copied, the report of his blood pressure for the last however long has been copied, and they are waiting at the door to get him loaded and get him to care. And that's something that family caregivers don't practice and don't even realize. I mean, he leaves from the nursing home to go to the hospital. They've got a list of everything going on with him.
Yeah.
He leaves
Yeah.
from your house and you're following him and you forgot to pack the medicine. You didn't bring the
Mhm,
of
mhm.
attorney and you may have even forgotten your phone.
Yeah, that's true.
So let's look at a respite care. And,
Yeah.
and I realize that is so hard to do. You're not abandoning someone. You're trying to stay alive.
Yeah.
That's right.
Remember,
Thank you.
grandchildren need you.
Yeah,
Yeah.
and call your local area agency on aging and see if they have the funds to help you with respite care right now. That's a good
Okay, thank you. I mean, he's a vet and I mean, this is the bad thing. We
Oh.
have
Yeah,
opportunities and we have services.
yeah.
He's 100% disabled. So again, it's just me. You know, I'm struggling.
Get in touch with Anna.
Yeah, I
Anna's
am.
gonna show you the way.
Yeah.
Kelly,
She already
care.
grabbed my hand and said, come on, girl.
that's right.
So Kelly, my phone number is 254-216-3668. Now, don't talk to Tisha because she'll tell you she never did call us back. But I will hold your hand and we'll get him into
So
the
you're right here in the Colleen area?
Oh my God, you're in Colleen.
I
Oh,
am.
okay. Yeah, pretty
Not
close.
far, not far.
Yeah.
And you can ask Guinevere because we know where she is and we'll put you on that same list and come after you if you don't take care of yourself.
Okay.
Yeah,
Guinevere
I will
can
give
tell
you a
you.
call.
Yeah, they will.
We got to have some laughter in all this. This is so serious and so hurtful. And so we're not being disrespectful.
Oh, I don't
We
take it that
laugh.
way. It's just so hard to have this type of conversation with people that are
Yes,
not going through this. I mean, people
yes.
care. I know they care,
But
but
they
the
don't understand.
day-to-day of it is just so, even when it's a good day, it's just so hard.
Yeah.
So Kelly, the VA in Temple is nice. Okay. And it's 30 minutes away. And Pinetti's is right around the corner if you like really good Italian food when you go
Yes, I
visit.
do. I've been there several times.
Okay. They're lovely, lovely people. And let's get him into care because your kids need you. And are you a grandparent?
I'm a grandparent, yes, a grand aunt, a grand everything. I feel like my life has been taking care of people in some way or another. So I think I'm tired. I really do.
If you need to come hide at the ranch, we can put you in a cabin and keep you
It
hidden
does
here.
have a cabin
And-
out there that you could
Yep.
stay in.
All
And
right.
when people get here, we tell them to let their family know there's no phone service out there. It's way out in the country, way out in the country. And
I
then
love that. I love the outdoors too. So
We want to
Yep.
get you back to yourself. So
Yeah,
take care.
let's get
Keep
him
joining us.
into the VA.
okay.
Other
right.
people are not able to make this move because of finances, because they weren't in the military, because they don't have that disability. You've got it, so let's get him moved.
Okay.
Right.
Thank you.
Thank you, Kelly. Take care of yourself and keep coming back.
I
Kelly, what
will.
We
you
won't
say you
harass you
done?
too much, but we want to check in on you is the main thing. So the
Yeah.
survey has popped up on the screen. You can see it there. And if you'll just take the couple of seconds to go through that, I see many of you are already doing that to finish that survey for us. We're running out of time. I'm used to 2 hours and here we go. Kay says, thank you. Shanda wants to know where to get the pain sheet. And if you go to Tam's website or look up pain ad, Google that, you'll be able to find it because I've done that myself before. Thank you,
It's
Kay.
all one word,
Yeah.
PAINAD in capital letters, and it stands for Pain Assessment in Advanced Dementia.
Yeah. So you can
The
find
name,
that.
I like the name.
Let's see, Anna. Oh yeah, Anna's something else. She's talking about the AAA and reaching out. So do that because they're in the beginning of their fiscal year. It's a good time. Can you please send me the survey, Naomi? I'll ask Naomi if we can get that to you. And Anna says, thank you. So thank you for all your kind words. Okay, wrap it up, Tam. You've got 4 minutes.
I want everybody to take Zarit's burden interview, ZARIT, And it is not a measurement of you as a good or bad person. It is a measurement of your stress level. If your number is over 40, you really need to be talking to a physician who understands what you're doing. Now, if you see a doctor, Glenda, and the doctor goes, yeah, that caregiving, that's hard stuff, you need to get a better doctor. You need to get somebody who understands. If they're in stage 5, you're doing the work of 12 people every 8 hours. If they're in stage 6, you're doing the work of 16 professionals every 8 hours. And there is a reason why you're exhausted. There's a reason why you can't see the light at the end of the tunnel. It's because you've been so beaten down by literally years of care. And some of you have gone from being the caregiver for one family member to another family member and now to a spouse. Some of you have been doing care for decades. Everybody has a point where they have to stop to protect themselves. Your loved one doesn't understand what's happening to them. They may be agitated, but we're going to blame everything on the doctor. They're in the nursing home because they need rehab and the doctor said they had to be here. They're in memory care because they need rehab and the doctor said they had to be here. And the doctor in the building knows that. They're not bothered by that accusation. And when you go visit them, they're going to tell you it's miserable. They hate it. The food here is bad. People are mean. And then as soon as you leave, I promise you, they turn around and go to play activities and do something fun. That is just something they do to their family member, especially their primary caregiver. And then they go back to playing with the other residents. We're social people, so social models work best. That's why there's so much socialization. If you're not able to do memory care or a skilled setting, a nursing home, totally understand that. It's so much money. You got to find a way to get breaks. Easiest way to get breaks is to try to build in respite care. So if my person was at home, I'd do respite for a month. Then I'd do 2 more months at home. Then I'd do respite again. Because Glenda, I know I can do 60 more days if I've had 30 days to rest. If I put my loved one in, I can't go spend 8 hours a day there. That's not, you're not helping. You're paying now someone to take care of your loved one, but you're actually going to come in and do the care. And so you didn't gain anything. When you move your loved one for respite or for the remainder of life, you can't go back for the first week. You've got to get rest. They've got to acclimate to the community. And you think about it as school. You didn't take your kid to school and then sit with them in the class. You left them there because they had to. This is now a matter of 2 people's lives at risk, your loved one who's terminally ill and you. And we want you to be the survivor. Okay.
All right. All right.
Gotta go.
I know.
Y'all are
Thank
the
you.
best. Happy New Year, everybody.
Bye. Be safe
Bye.
today.
Bye.
Okay, thank you so much for joining us today. I'm so appreciative of the work you're doing and people you're caring for. Anna, thank you so much. You're just a warrior out there. You all are. You are heroes for sure. So take note of when we will be back on March the 5th. If you have questions and you could submit them early, it gives us a chance to be more organized. Today, I felt like we had to rush so much. It just kind of threw me off because I didn't know that we had this time constraint. Right now it's set for 10 o'clock in the morning, but talking to Tam earlier, I'm thinking that wasn't what her intention was. She's always been on at 1 o'clock in the afternoon, so I'm going to leave that between her and what the foundation and figure that out. But you can see it.
It's early.
What?
It's dirt early.
Yeah, for her, for you too, Guinevere.
Yes, that's
Anyway,
why I was late.
I kind of like 1 o'clock too. I was surprised when it moved to 10 this morning. But anyway, we'll get that worked out. Just watch for the calendar. But those are the firm dates. So please submit any questions, your situation, Gordon's situation. I wish I could have taken more time, Gordon, to read all of that for everybody, but they could see it on the chat box. And you explained it well when you came on live. So I appreciate that too. So, all right. Take care of yourself. That's my message to end the session today. Everybody come back and be with us again in March, May, July, September, and November. I'm glad we have those dates ahead of time this time. I appreciate what you do. Thank you so much. And I hope that you have a very good, whatever that means for you, New Year. Bye-bye.